Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Today's talk, this is going to be the first in a new series that I'm going to do for you guys. And for lack of a better name, I'm just going to call it the deep dive. I couldn't think of anything else. But I'm going to take a much deeper dive into a particular aspect of age management medicine, meaning nutrition, exercise, hormonal optimization. And I'm going to present to you material that is going to be at a much higher level than I typically present. And I think that you're going to find is going to be much higher than what you can find certainly on any of the bro science forums or out on some of the general channels that are out there on YouTube. This is going to be at the medical school level and higher. And I realize this is not going to be everybody's cup of tea, and it's not designed to be. If you're a physician, if you're a PA, nurse practitioner, naturopath, etc., that is involved in the prescription of hormones for men, or for women for that matter, if you are involved in, quote, anti-aging medicine, which I hate that term, but, I think we're stuck with it. If you're involved in anything, remotely like that, functional medicine, etc., then I think you might find this of use, and I hope that you do. I've said this before, but unfortunately this part of medicine is filled to the brim with quackery and things that are not evidence-based. And again, just because something doesn't have a strong body of evidence in the medical literature doesn't mean it's not worthwhile. But there's a lot of stuff out there that just has no support. So my goal with this is to give you guys solid evidence-based information that can justify the practice that you're doing and will allow you to help patients in an evidence-based manner. And there's a number of different advantages to practicing this way, not the least of which is that if you ever get called to task by a physician in another specialty, an endocrinologist, a urologist, or andrologist, who's questioning the way that you prescribe testosterone, for example, which we're going to talk about today, then you can be ready to justify what you're doing, not only because it makes sense, but because you have a strong body of medical literature that supports what you do. And that may even come handy, God forbid, if you ever get hauled in front of a medical board and you have to justify your practice, you're going to be able to do that. So that's the kind of information that I want to present to you guys in these deep dive lectures. It's going to be a little bit geeky, a little bit of a deeper dive than perhaps you're used to with some of my other lectures. Okay. Now, so with that said, what we're going to talk about today is actually some of the pharmacokinetics of testosterone therapy. And there's something that I noticed over the years that always kind of perplexed me a little bit. And it was the fact that, you could have two men who seemingly were very similar, same age, same height, same weight, same body composition, and you could give them both an identical dose of testosterone, say 100 milligrams a week, intramuscularly, subcutaneously, whatever the case may be. And when you check their levels after they've achieved a steady state, perhaps on day 7, sometimes you get vastly different lab values. And I attributed that sometimes to there are individual variations between lab assays, the way that the test is performed, that sort of thing. But, I always wondered that, there must be some sort of a genetic factor here. And it turns out that there is. And that's what we're going to talk about today, in addition to some of the other factors that can influence testosterone levels in men. I want to show you guys this study first. And the study itself has very little to do with what we're going to talk about today, but I want to point out the different range of testosterone levels that they had in these subjects as an example of what I've seen in clinical practice, and perhaps you have too. So this is a study in the journal Sexual Medicine from 2015, Pharmacokinetic profile of subcutaneous testosterone enanthate delivered via a novel prefilled single-use auto-injector, a phase 2 study. So the purpose of this study was to demonstrate that with testosterone enanthate, not only could you deliver it subcutaneously, but you could use this little auto-injector that Big Pharma wanted to put it in, kind of like an EpiPen. Now, I think it's sort of silly. You don't really need to do that, but it's kind of cute, and there are some people, I guess, that like it. But essentially this study showed, you can do that. You get good levels. There's no problems there. But as I was going through the paper a while ago, I looked at the serum levels that they achieved with the patients that they used in this particular study. And they used 39 different men, and they did a really good job of standardizing this group of men. I'm going to show you, based on this chart right here, some of their characteristics. So they all had a very similar weight, right? Like 91.75 kilos was the low, or excuse me, 90.35 kilos to a high of 93.16 kilos. So like fairly average, very similar heights, as you can see here. And at least in the 50 milligram and 100 milligram testosterone group, they had very similar baseline total testosterone levels. They're actually, looks like pretty hypogonadal, 215 and 201. And so these are like a fairly homogeneous group of men. And then they injected them with 3 different doses of testosterone and then they subcutaneously with one of these little fancy auto injectors. So they either gave them 50 milligrams, 100 milligrams, or 200 milligrams. And then they checked their levels on day 7. And they showed, this is on the next chart here, they show what their mean levels were. Not surprisingly, the 50 milligram dose didn't really move the needle so much, so to speak. They had an average of 422. If you got 100 milligrams, your average was 895, so quite a bit better. And then obviously if you had 200, your levels were super physiologic. But what I found interesting was the range. So even in the 50 milligram group, you had one guy who was as low as 257, and then another guy that was as high as 673. And you can see it in the other groups too. I mean, the 200 milligram group, the low was 681, and then the high was 3,758. So, wow, I mean, there's a huge range there. And what is it about those guys on either ends of those, on either ends of that spectrum that caused them to have such totally different, levels? What's up with these outliers? Because I've seen this before. I've seen some really unexpected numbers in patients, and as you can see, it's not because of their height, it's not because of their age, it's not because of their weight or BMI, because all of that stuff was standardized. This is another study that showed essentially the same thing, but this time with free testosterone, hormone profiles after intramuscular injection of testosterone enanthate in patients with hypogonadism. This is a Japanese study published in Endocrine Journals from 2006. And as you can see over here in this chart, they gave these guys a single intramuscular injection they just gave 125 milligrams, so not a crazy high dose. And then they checked their levels. They only had nine subjects in this test, or sorry, in this study. They only had 9 subjects in this study, so it's not a huge study. But look at the wild range here. So this is all the subjects here, and they tend to cluster like between somewhere, I would say between 15 and 18 picograms per ml, which is about what I would expect. But you did have one guy that was lower than that. But then what's up with this guy? This guy here was a total outlier, and he got up as high as 44.4 picograms per milliliter. And they mentioned in the study, they said for unknown reasons, because again, all of these guys, all of their characteristics were standardized, including SHBG, which that was the first thing I thought, well, okay, maybe he just had really low SHBG and that's why his free testosterone was so high. Not the case. So it was actually very similar. They were all very similar. They had very similar starting total testosterones, very similar starting free testosterones, SHBG, albumin, LH, FSH, TSH. They checked all these different things, and they were all, their pre-injection levels were all like fairly homogeneous. So they just said, we don't know, he's an outlier. Well, as we go on here, I'm going to show you that I think there's a good explanation for this. So, but before we do that, let's get back into some organic chemistry. You thought you were done with organic, but you're not. So, as you know, the different testosterone formulations that are available worldwide are in an esterified form. So what is an ester? So an ester is a derivative of carboxylic acid. This is what carboxylic acid looks like. Okay, and in this particular case, the hydrogen of the carboxylic acid is replaced by this R prime group, okay, which is usually like a methyl group, ethyl group, maybe a benzene ring. It's something else. Okay, so that's what an ester is. And what that looks like with the different testosterone formulations is this. So here's propionate, we got enanthate, cypionate, and undecanoate. And what you can see here, testosterone is a steroid hormone, right? So it has this steroid backbone that you can see right here. And there are 4 rings, the A, B, C, and D ring. This is the standard steroid hormone backbone. Comes from, looks just like cholesterol, which might look familiar to you. And what they have done in order to increase the half-life of the testosterone is at this 17 group here, it's only on the D ring. So on the D ring, they've taken this 17 position here, and they have added an ester to it. And depending on the composition of the ester and the length, the number of carbon atoms especially, that has a pretty significant effect on the half-life of the testosterone formulation. So you can see here with propionate, there's a very short ester group here. 1, 2, there's only 3 carbons on it. Okay, as you move over to enanthate and cypionate, so enanthate is here, cypionate is there. Now, they're roughly the same size, and there's only one carbon atom difference between those two. Even though they're different esters, the total number of carbons is almost identical. I think it's different by 1. So I think cypionate has 1 extra. And as a result of that, as I'll show you later, the pharmacokinetic, the curve and the half-life of enanthate and cypionate are very similar as a result of that. But as we go over here to undecanoate, look how long this carbon chain is here. This has everything to do with why undecanoate is considered a long-acting testosterone. Now, in order for this testosterone here that has an ester on it to become biologically active, to be able to measure it in your serum, an enzyme, which is called an esterase, has to come along and it has to cleave off this ester. And this is the key to understanding why, in many cases, you'll see different levels in different men who otherwise seem very similar. Okay, and then this is the pharmacokinetic curves of the different types of testosterone, as I mentioned before. So here's propionate, which, as we know, is a short-acting testosterone. You get a dose of propionate either subcutaneously or intramuscularly, and what do you get? You get a nice big peak, and then rapidly metabolized, and it looks like by day 4.5. Certainly by day 5.5, you're back down to where you were before. And then, as I mentioned before, so this is a cypionate and enanthate curve. They're overlapped over each other. They're virtually identical. So I know people argue about this sometimes online, but the fact of the matter is that cypionate and enanthate are, for all practical purposes, they're interchangeable. Cypionate in the United States is by far the more common. Enanthate is available. It is a bit more expensive, but given how similar they are, you might as well just go with cypionate. And then finally, here's undecanoate, and look at this long, big curve here. First of all, it takes a long time to reach peak serum levels. You don't get that till day 7. All right, compare that with propionate, which it looks like, gosh, probably within 8 to 12 hours you reach your peak serum concentration, and then you have this nice slow decline with your undecanoate over time, which is why some guys like it. Okay, undecanoate has issues. It's not my go-to, but there are some advantages to it. Okay, so let's talk a little bit more about pharmacokinetics. It should be like distantly still in your mind from medical school. So what is pharmacokinetics? I mean, the best way to think about it is basically what the body does to a drug. And when a drug is ingested, you have to think about 4 different things. One is absorption, distribution throughout the body. There are different body compartments: water, fat, different organs, muscle tissue, etc. So that drug, when it enters your body, is distributed in these various compartments. It is then at some point metabolized, sometimes in the liver, sometimes in the peripheral tissues. It may have multiple different metabolites. Some drugs have 5, 6, 7, even more metabolites. Some of those metabolites are active, some of them are inactive. And then at some point it has to be excreted, right? So either is excreted in the urine or in the stool, that sort of thing. Now, as you get older, there are major changes in all of these things. Other things, obviously, that can influence this is your body fat percentage. Now, many drugs are protein bound, so your albumin status can have a huge impact. I run into that every now and then in the emergency room. There are drugs like warfarin or Coumadin, which is extremely potent blood thinner that's been around quite a long time. Certain anti-epileptic drugs like phenytoin, these are all bound to albumin. And if somebody has very low albumin levels, sometimes they can have toxicity with either one of those drugs that they wouldn't normally have, or another person wouldn't have who had normal albumin levels. So there's a lot of different things that can influence these four things. Body fat percentage is one of them, and you can argue too. Testosterone is a lipophilic drug, or hormone, and so body fat percentage, certainly can play an influence, body fat percentage certainly could have an influence in the pharmacokinetics of testosterone. So testosterone, thankfully, the pharmacokinetics of testosterone are fairly straightforward. It follows something called first order kinetics with a one compartment model. So you learn this back in pharmacology. I know I learned it, but I had completely forgotten about it. But what does first order kinetics mean? So first order kinetics, basically it means that the rate of change of a drug concentration is proportional to the amount of the drug that is remaining. So if you have a high amount of drug, you have a high amount of absorption. As the amount of the drug goes down, the absorption starts to slow. So this curve here, this isn't testosterone, but you notice it looks very much like testosterone. This could be any generic drug that has first order kinetics. And what you see here is that the peak concentration, you reach the peak concentration when the rate of absorption, which is this dotted line here, and the rate of elimination intersect. That's your peak. Okay, and this is exactly what testosterone does. And it doesn't matter what the formulation is, what the ester is. It follows this first order kinetic model. It's actually fairly simple, fairly straightforward. And then it also follows what's called a one compartment model. Thank God, because these 2 and 3 compartment models are extremely complex. But the one compartment model, it essentially assumes you get homogeneous distribution of the drug throughout all of the tissues in the body. So it doesn't sequester in one sort of tissue and then reach equilibrium with another area of the body like the plasma. So we'll see in a 2 compartment model. So it's fairly straightforward. So here, the amount of drug in the body is related to the amount of drug that is given, obviously, and then that is influenced by the rate of administration. So you either give a bolus, or it could be infused in an IV drip. I do a lot of IV drips in the emergency department. And then the amount of the drug that's cleared here, which is A2, is directly related to the elimination rate constant. So this comes out, you can get a mathematical equation from all of this, which is this right here. I'm not going to go into that. But if you know the variables in this equation, you can very easily, in the majority of cases, you can estimate what the serum concentration of a given drug is after a given dose. If you know for sure that it follows this model, you can use this equation. And, there used to be questions like that on our pharmacology tests where, we'd have to, calculate the concentration 2 hours, 10 hours, 12 hours, etc. And thank God I don't have to do that anymore. So moving on here, this diagram is actually really helpful in understanding this concept because it can be a little bit obtuse, a little bit abstract, and it helps you understand the difference between a one compartment model and a 2 compartment model. So as I mentioned, testosterone is considered this is a one compartment model drug, and so that is our little guy up here at the top. So you see the needle going in his arm here. He gets a shot. And this doesn't matter whether it's IV, intramuscular, or subcutaneous. The drug is given, let's just say a single dose, and it is equally distributed throughout all of the body compartments, all the body tissues, plasma, heart, lungs, kidneys, liver, etc. Now, clearly, it is a lipophilic drug, testosterone, so are there going to be some subtle differences? Yeah, but for all intents and purposes, we can consider this to be a one compartment drug. Now, this is different than a 2 compartment drug, and there are 3 compartment drugs too, but a 2 compartment drug, so it starts out the same. See, little guy, he gets his injection, and then the plasma levels will rise very quickly, as you would expect. But then the drug concentrates in a particular tissue, one or more different tissues, and then so that causes the plasma level to go down. We have concentration of the drug in this, given compartment. we'll call it compartment 2. And then you start reaching equilibrium between compartment 2 and compartment 1. Compartment 1 we can think of like as the plasma. So a good example of this is a drug that I don't see as much anymore in the emergency room, but I used to see a lot, is digoxin. So if I give somebody an intravenous dose of digoxin, which I can't remember the last time I had to do that, digoxin, the serum level will go up. It is rapidly absorbed and concentrated within muscle tissue, especially cardiac muscle tissue. And then from there, it reaches some sort of an equilibrium between plasma and that muscle tissue. It goes to other organs, obviously, to other tissues. And then it's also complicated by, there's this enterohepatic recirculation, which can complicate things a little bit, but essentially that's still a 2-compartment model. So don't worry about the 2-compartment model very much. I just wanted to bring that up as a comparison so that you have an understanding of the way that drugs are distributed throughout the body. It can get fairly complicated. Thankfully, testosterone is easy. It's a 1-compartment model, first order kinetics. It's really straightforward. Okay, so as I mentioned before, in order for testosterone to do its thing, that ester has to be cleaved. Now, as testosterone, let's say cypionate, for example, is floating around in your body, let's say in your blood, and it has the cypionate ester on it, your body can't do anything with that. It does not bind to the androgen receptor. It's not picked up by albumin. It's not bound by SHBG. It's not until that esterase enzyme comes along, clips the cypionate off of it, and now you have a free-floating testosterone molecule. Odds are SHBG is going to come and bind that up. It may bind more loosely to albumin, or a small percentage of it, 1 or 2%, as you, I'm sure, are well aware, is going to remain dissolved in the serum, just as like free-floating testosterone. And there's going to be equilibrium going back and forth between there. Of course, what is esterase? Esterase is an enzyme. Where do enzymes come from? Enzymes are encoded by DNA, and as we all know, we're not all genetically identical, right? So, I may have a esterase enzyme that cleaves or interacts with a given medication X that could be different than the esterase enzyme that you have, in which case I may have different serum levels than you do, right? And it may not be clinically significant. The levels may not be very different, but in some cases it can be vastly different. And if that medication is a blood thinner, if that medication affects the electrical conduction of your heart, if it affects your brain or your neurotransmitters, I mean that could be a big deal. So I think these are underappreciated, and as time goes on, I think we'll have better understanding of the genetic differences in these esterase enzymes, and we'll have to be a little bit more cautious in how we prescribe certain medications. So this is a super interesting study, which I think it nails this clinical question that I've had for so many years about why do we get these vastly different blood levels in patients who otherwise seem very, very similar. Okay, so this study is bioavailability of testosterone enanthate is dependent on genetic variation in the phosphodiesterase 7B, but not the UGT2B17 gene. I'm not going to try to pronounce that. So this is from September 2010 edition of Pharmacokinetics and Genomics. And super interesting study. So they found a group of men who had a mutant form of this phosphodiesterase 7-bravo gene. Okay, now this gene encodes a 3' 5' cyclic nucleotide phosphodiesterase, of course, right? Now this phosphodiesterase enzyme is involved in hydrolyzing cyclic AMP, cyclic GMP, which, as you remember, is involved in cellular signaling in the second messenger system. So it's like really important. But if you have a mutant form of this, then you may have a version of the gene that doesn't work as well. And it turns out that this gene that codes this enzyme, this particular esterase, is the one that's involved in the cleaving of at least testosterone enanthate, and I'm going to show you also nandrolone, and probably the other esters of testosterone, although we don't quite know for sure. We don't have the data. And there could be other esterases, like I said, there's many of them that are also involved in this process, but this is the first one that they've really pinned down and said, hey, yeah, this one is involved in testosterone enanthate and in nandrolone de-esterification. Okay, so what did they do here? So they found they found these guys that had a mutant form of this gene, of this esterase, the gene that coded the esterase enzyme. And then they compared what would happen after a dose of testosterone enanthate with a group of like normal controls who had normal copies of the gene. And what they did is they gave these guys like a big slug of testosterone enanthate. So they gave them 500 milligrams intramuscularly, and then 2 days later checked their total testosterone levels. And we would expect them to be sky high, right? After a huge super physiologic dose of testosterone, and especially 2 days later, their levels should be through the roof. And what we see here over here is in this chart. Now, they called the wild type version of this gene, they gave it the letter A. And remember, you get one copy from mom, one copy from dad. So they showed if you have at least one copy, so it's all you need is one copy because it's an autosomal dominant gene, then you had a normal response. And so look at what happened here. So these black bars here, this is the pre-testosterone levels. So both groups, regardless of what allele you had for this particular gene, you had very, very similar serum total testosterone levels. So 2 days after a 500 milligram intramuscular dose, as you would expect, boom, look, it's close to like 1900 nanograms per deciliter, which is what you would expect, right, in a normal individual. But here's the interesting part. If you had two copies of the mutant allele, so if you were, which is, again, homozygous recessive, so you have to have two copies of this defective gene, look at the difference. So you still had you still had a decent rise in your testosterone level, but you had a 650 point difference just with one change in this particular enzyme. So clearly there are other esterases involved here. There have to be, because if this was the only enzyme involved in cleaving the enanthate ester and it was completely knocked out, then you probably wouldn't get much of a detectable level at all. So this, there are either other esterases involved in the cleavage of testosterone enanthate, or this defective copy still had some activity, presumably. But that's a really impressive difference. I mean, a 650 point difference with the exact same dose of testosterone, same starting level in men who are otherwise, an otherwise homogeneous group of men. And then, the question is, okay, is this involved in the de-esterification of other steroid hormones as well? And this is a study, PDE7 Bravo is involved in nandrolone hydrolysis. So we know it's heavily involved in testosterone enanthate. We know that it's involved in nandrolone, which nandrolone decanoate, right? Decanoate, depending on where you come from. That's an ester of nandrolone. So you require you need enzyme activity of this PDE7 Bravo in order to cleave that ester. So, and again, they're very clear in here that they don't know if it's also involved, for example, like in cypionate and propionate, but I think the odds are high that it probably is. We just don't know at this point. It's definitely involved in enanthate, definitely involved in nandrolone decanoate. So what does this show? This tells us that genetic polymorphisms in the PDE7 Bravo gene, they're kind of important, right? They play an important role in determining what a patient's serum testosterone levels are going to be when you put them on therapy, and then you follow them up and you check, you check their levels. And this explains why you're going to see, in some cases, vastly different serum testosterone levels in men who are otherwise quite similar. And this is the reason why you might need to push that dose a little bit higher. So on paper, it might look like you're giving somebody an excessive amount of testosterone, but the reality is when you are checking their serum levels, you are getting levels that are still within the normal physiologic range. And this is the reason. This is the reason. All right, guys. Well, I hope you found that helpful. This is the first of the deep dive series. Like I said, I will probably do these once a month. Let me know if you like these or not. If it's not to your liking, I won't do them. I won't torture you with this sort of stuff. But this is the level of expertise and the level of background knowledge that, in my opinion, I think if you're going to be prescribing hormones, if you're going to be taking care of patients in this age management, specialty area, I do think that you really need to know your stuff, and you need to know the medical literature, and you don't want to be practicing cookie cutter algorithmic medicine, which unfortunately I see a lot of that. You don't want to practice medicine that doesn't have a good evidence base within the scientific literature, because you want to be able to always support what you do with good evidence. Okay, that's all I have for you guys today. I will catch you next time. All Man Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.